On today's episode,
people with ADHD, because of the ADHD, can be more susceptible to depression and anxiety and substance abuse. Anxiety and depression can ruin you as far as being emotionally accessible to people that you care about. The sad part is most people don't realize what resources are available, and a lot of the services will include a warm line and a hotline and a crisis center that you can call. Meal would be poached lobster tail and fettuccine Alfredo with crab sauce.
yum, delicious, skinny, hungry, cake, fat, scale, nutrition, fitness, strength, longevity, calories, body image, craving, lose weight.
What does it all mean?
Hungry, adjective, having a strong craving or desire. Stunt girl, noun, one who takes calculated risks to yield extraordinary or magical outcomes.
You're listening to the Hungry Stunt Girl podcast.
Here's your host, Heidi Germain Schnapoff.
Hello, and welcome to the Hungry Stunt Girl podcast. I am Heidi Germain Schnapoff, professional stunt woman for film and television, and this is episode 15. I can't believe it, 15 already. I wanted to have today's guest on because I've been receiving a lot of messages recently regarding mental health. And, well, first of all, I want you all to keep in mind that this is not medical advice. This is just a chat that I'm having with a medical professional who specializes in mental health. He's a psychiatrist, and he's also one of the most wonderful humans that I know. And he has the most soothing voice I have ever heard. And I actually told him he should start his own podcast because of it. Well, we were able to address some basic questions regarding the use of medication and therapy to treat mental health, some certain mental health issues, and also address the stigma that's attached to mental health as a whole. It's a really valuable conversation, and I realize as much as I focus on what I put in my mouth, what I put in my body, how I train, I've realized over the years, as I'm sure many of you have, that it is equally, if not more important to focus on your mental health. I am hoping you guys get something out of this. I know I learned a lot, and I hope you do as well. Please also feel free to contact me if you have any other questions that maybe I didn't answer here, or if you are having trouble finding maybe resources in your town or your state other than the ones listed in the notes for today's podcast. I would be more than happy to help in any way, so please reach out, Heidi at thehungrystuntgirl.com. And without any further ado, here is my interview with Dr. David Liskov.
Hungry. Stunt girl.
Today's guest is a practicing psychiatrist and mental health expert from northeastern Pennsylvania. He has over 39 years' experience in the medical field and has worked as a medical director for First Hospital in Kingston, Pennsylvania, clinical associate professor in the Department of Psychiatry for the Commonwealth Medical College in Scranton, Pennsylvania, medical director of the Behavioral Medicine Unit for Mercy Special Care Hospital in Nanticoke, Pennsylvania, and myriad other consulting positions, as well as his private practice. Not only is he married to another incredibly kind physician who practices emergency medicine, he has raised two amazing humans, twins, who have followed in their parents' footsteps and are kind and incredibly passionate doctors themselves. Please welcome today's guest, Dr. David Liskov. Well, let's start from the beginning here. Now, I have so many questions for you. I also remember when I was younger, you made... And this is actually one of the first reasons I thought that you would be fun to have on, other than the fact that you deal in the world of mental health, which is a big part of just health overall. And completely unrelated, you made an Alfredo sauce once.
Fettuccine
Alfredo.
That's my Christmas Eve dinner.
So you made that for, I used to babysit Dr. Liskov's kids now they're both doctors, they're twins. We would, make little lunches here and there, but I remember one night I came over for dinner and you cooked fettuccine Alfredo, and I nearly died. Not mainly because it tasted so good, but also probably because I almost had an instant heart attack, but it was so good. And I remember we started talking about food that night, and I was a lot younger, but since then we've talked about food a bunch, and I thought, this is perfect. He's not only a doctor and super smart, but super into food, so this would be a fun time. So, okay. So where are you from? Let's give it a little bio,
Small
little
scenic
intro.
town in northeastern Pennsylvania. I'm from DuPont, Pennsylvania. I think the population was like 7,000 people. And my uncle one time was the mayor of DuPont.
Really?
And I grew up there.
Your uncle was the mayor of
He
DuPont?
was the mayor of DuPont.
No way.
Hey, it worked really well for me because one time I did get a ticket for having an expired registration. He got me out of it because he had clout.
Yes.
It was pretty cool.
So from DuPont, brothers and sisters.
I have one brother who's a psychologist, and I have one sister who's actually a nurse who does the utilization review in the psychiatric unit at Johns Hopkins in Baltimore.
No way.
Yeah.
And where's your brother?
My brother's a psychologist. He's at the University of Scranton. He's the head of their counseling center.
Oh, wow. Oh, that's cool.
We think it's my mother. She kind of got us all into psychiatry.
Did you initially want to go into medicine or
Actually, I was a chemist. I never took a psychology course in my life. I was a biochemist in college. I changed my major from biology pre-med to biochemistry. I stayed for a master's in biochemistry. I didn't know what field to go into, so I went to Hopkins to work as a researcher with an idea of going for a doctorate. And unfortunately, all the doctorate people that were there had indicated that it wasn't a really good thing to do, and they didn't recommend it. And we were in the Department of Dermatology, so I got to meet with a lot of people that were doing medicine, and I decided I wanted to go to medical school, so I did. I went to medical school, but my idea at the time was to be a family practitioner. And I did a psychiatry rotation when I was a student in medical school. I loved it. I fell in love with it. And when I had my exit interview, after my interview, they wanted me to come back. And I spent 2 years in medical school trying to talk myself out of psychiatry, and I went into it anyway. And I even did a regular medicine internship just to hedge my bets, because at the time when you went into psychiatry, it was to fix your own problems, and it wasn't to go into the field. It was to just get better and go back into medicine.
Wow.
And when I was an intern, I was offered a second year in internal medicine, but they said, look, if you decide you don't like psych, come back and do medicine, and we'll give you a slot. Because someone will drop out and you could take their spot. I went into psychiatry and I never looked back. I loved it. I just really liked it. I was a biochemist. Psychiatry has a lot of pharmacology, and I really enjoyed that. And also, I like talking to people. I like interacting. And in medicine, it was a lot of protocols.
Yeah.
And the protocols were kind of, well, they weren't the best. I mean, when you saw a patient that had acute asthma, you treat them and you felt great because they got better. But then you realized it was the protocol. You use the same protocol over and over and over again. And in psychiatry, we use protocols. We have ways we do things, but they don't always work. So it was like great, because every day was a little different. Even if you saw the same kind of things, the solutions were different, and I really enjoyed that a lot. So psychiatry really appealed to me.
Would you say like it's a different kind of problem solving because it's not really a
It is a different kind of problem solving because you do get close to patients. It was funny, when I was on medicine, if a patient had some emotional issues, they interfered with your ability to treat them. But when you're on psychiatry, you enjoyed those patients because that was what you wanted to look at.
Right.
That was the factor that made you enjoy talking to them and seeing what you can do to fix them. I do have to say, too, the pharmacology in psychiatry is amazing. People get better. They get better with medications. I'm a firm believer in the combination of therapy and medication, but the medications work very well to help patients get better. So I really do enjoy it. And I've been doing it for a long time. I still enjoy it. It's actually a fabulous career.
how long? Okay, you've been doing it a long time. How long have you been?
Over 30 years.
Wow, practicing for 30 years.
Yes.
So skip back. So 30 years ago, when did you meet Cindy, your wife?
When I was in college.
In undergrad or?
When I was in undergraduate school, I had to take a physics course over the summer. She had transferred from Shippensburg State College to the University of Scranton. She decided she was going to go to medical school. She went into pre-med. And I met her doing a summer physics course. And we kind of were friends. And then we got pretty serious and we stayed together.
Aw. And she's also a
She went to
physician?
Jefferson for medical school. I went to Baltimore to work in Johns Hopkins, and then I decided to go to medical school. I was there, and she finished up at Jefferson, and she decided to do internal medicine. And then she always wanted to be an emergency room doctor, but she thought she'd do internal medicine and then go into the emergency room. And then one of my friends that I met on a rotation in emergency medicine talked her into just going right into emergency medicine. Wow. So she did her internship in internal medicine and went into emergency medicine, and she loved it and thrived. And she did that for 30 years. She just retired last year.
Wow. Do you have any plans on retiring?
Not anytime soon. I enjoy what I do.
Really?
So no, it's too easy. You sit down, you don't have to move around. You don't have to hit your target heart rate. I love psychiatry. Oh, wow. So I can do this forever.
How is your job or what you do? Has it progressed over the years? Like, did you start off?
Well, I had kids. I had twins. And my wife, she was an ER doc. She had fixed hours. So I had to tailor my practice over my children. So I did a lot of different things. I never worked for anybody full time. I always worked here, there, and everywhere. And it worked. I never missed a Halloween party. I never missed if they had a snow day, I had a snow day. I had a private practice. I moonlighted everywhere, and it worked out beautifully. And when my kids went to college, I was an empty nester. So for the first time in my life, I actually took a job. And I was the medical director of a psych hospital, and I did that for 9 years, and I retired from that about a year ago.
What does that entail?
Well, you were in charge of all the doctors, and you were in charge of making sure all the patients were seen every day. And it was pretty cool. And I did clinical work, too. I did a lot of inpatient, too. But at that time, I'd given up my private practice, and I decided to just basically do one thing. And it was very rewarding. I enjoyed it, and I stepped down from that last year.
And now what are you doing?
I'm still a clinical psychiatrist. I do work at the local prison. I do crisis all over this great land of ours, locally, through the counseling centers in like 2 counties. We do crisis. We do like phone calls in the evening for crisis assessments. The local jail, I do that. I see prisoners there. And I still work at the hospital that I was medical director of in a part-time basis, and I do inpatient psychiatry.
What's your favorite part of doing that kind of work?
The interaction with patients. I enjoy that. Even though there's a lot of paperwork and a lot of issues, it's still the most fun part of my day, just talking to people, interacting with patients.
Kind of, yeah, because I suppose that would be, like you said, diagnosing or treating something like asthma or whatever would be, here's the solution to this. I feel like no matter... Like you said, there's a protocol, but it seems that to be like every situation is just, no matter how similar, they're all different. Like every person's different. And
pretty much, yeah.
Do you find a lot of, have you found different outcomes with people that kind of come in with similar, I don't know if it would be like a symptom or I'm feeling sad. And then you go from there and then someone else could come and say, I'm feeling sad. Or what kind of...
So many factors, especially nowadays in society. You have to look at substance abuse issues, relationship issues, occupational issues, and then the history of the patients. A lot of patients have a lot of baggage. A lot of patients have had issues with foster care, abuse issues, bad relationship issues, issues with nurture and nature. So everybody's different. So if somebody comes in with depression, the etiology of the depression is multifactorial. So it really is, that's the fun part about it. It's just to sit down with somebody and tease out what's going on. Is it a personality issue? Is it because of circumstance? Is it a situational issue? Is it, and you have to collate all that information. And it's like problem solving. And it's very interesting. And I really enjoy it because when patients get better with psychiatric problems, they really get better, and it's nice to see. So it's very rewarding, when you get a patient who's on the cusp of like suicide and depression, and you have them see that they're looking at life in a different way. It really is rewarding.
Oh wow! You said crises is a lot of that? Does a lot of that kind of revolve around? What kind of crisis would that be? Like?
Well, every emergency room in the area has a crisis service. So if a patient comes in because the police brought them in because they were on a bridge, because they were suicidal, or they just the family decides to send the patient to the hospital because they're worried about their behavior, or a patient may come in and say, look, I'm really losing my will to live and I may want to kill myself. They present to the emergency room and then they do a crisis evaluation. And a lot of times the crisis will call me and we'll review the issues and the concerns to see if they have an adequate support system, if they really are in jeopardy of losing their lives and they require hospitalization, or we can do something more in an outpatient area. So those things happen like all the time.
Wow.
And with crisis intervention, it's wonderful because you get to interact with the crisis people who are seeing these patients. And you're worried that you may lose a life if you don't make the right decision. So they're pretty critical decisions that you have to make. But it's a very rewarding part of what you do. So.
And you work with when people come into these crisis centers, or they call
Right.
in. Is there a kind of like a triage, or is there like a chain of command? Like they would talk to somebody and then they would eventually get to you, or how does that work?
Absolutely. What happens is if you have a problem emotionally, and I don't know if you know this, but if you call a pharmacy, if you call a physician's office, if you call any healthcare provider, the first thing you're going to hear on the recording is, if this call is an emergency, call 911. And that's what they recommend you do. And 911 will tell you if you need to go to the emergency room or not. When you go to the emergency room, that's when, if it's a physical problem, you see the ER doc and you'll get the medical triage. But if it's a psychiatric problem or an emotional problem, they'll do the medical clearance to make sure it's not because of some medical etiology, but then they'll send you over to the crisis service for the evaluation. And then the crisis worker will do the evaluation, call the doctor on call, and review all the details to determine, what do you do next? Do you go to the hospital? Do you do outpatient? Or is everything okay and they can go home? And that's what you do.
Now, you mentioned that you really like the interaction with people. And my question to you, a big question I have, personally, I know the answer for myself, is when I'm better, when I can't sort things out. I've been diagnosed with ADHD later in life, which I thought was interesting that it was an 8-hour test for something for keeping your attention. But it was, spread out over a few days and all that. But how much do you think that your mental state can affect your physical state? Do you find that when you work with people that there is some sort of connection that... Absolutely, no doubt in my mind. Usually when you examine a patient for depression, you're looking for neurovegetative signs. Mm-hmm. Are they sleeping okay? Do they have energy? Do they have focus? Do they have concentration? Usually when you're depressed, the first thing that goes away is your ability to enjoy life. The things that you used to enjoy, the things that you wanted to do, you lose your interest in them. And people go, well, I've been working. I haven't missed a day of work. Well, yeah, because when you go to work, you hang your emotions on the hook at the door and you walk in, they're paying you to work. They don't care if you're emotional. So work is a great place to go when you're depressed because you have to tune out your problems. It's at the end of the day when you go home that you just don't feel like watching your favorite show or playing with your dog or enjoying your children or just having a good life. So one of the things that depression does, it's very insidious. It just takes away your leisure, your focus, and your fun in life. And if you don't recognize that, you'll never do anything about it. The other thing, too, is, yes, physical issues are very tied into emotional issues. If you have issues with guilt especially, issues like migraine headaches, back pain, irritable bowel syndrome are absolutely amplified because of those conditions. Because if you feel guilty, that's what happens. Mm. Anxiety and depression can ruin you as far as being emotionally accessible to people that you care about. So if you have a support system and a partner and friends, you just don't feel like doing anything. So unfortunately, it's a vicious cycle because now you're not socializing. You're not doing things you enjoy. You don't feel like it. Mm-hmm. So it spirals down. And if you're not careful, it can be a problem. A lot of people have psychogenic symptoms. Now, psychogenic aren't psychosomatic. Psychosomatic people are people that imagine they're ill. Psychogenic is when the stress that you're carrying emotionally manifests itself in physical symptoms. You can get headaches, you can get stomachache, you can get all kinds of problems physically because the mind is very powerful. And you can get psychogenic illness. And a lot of times people go to their doctor and they'll go, my stomach's bothering me, I'm having issues. And they're missing the whole point because they're looking at the physical problem, which is the manifestation of the psychiatric problem. Wow.
And you're not going to get the appropriate therapy. You may get some Mylanta, some Maalox, some Zofran for nausea, but you're not going to get better because you're not addressing the source of the issue, which is the emotional problem. You're just addressing the physical problem, which is the result of the emotional problem. So yes, they do go hand in hand. I had a therapist who was hysterical in our hospital. the therapists worked 5 days a week from Monday through Friday. But they decided to start making it so the therapist was available on Saturdays. So one of the therapists came to see me. She had migraine headaches. And every Saturday she had her migraine headache and it would go away Sunday morning. Now she was in a panic because now she had to work Saturday in exchange for taking Monday off. So she said, what do I do? What if I get my migraine every Saturday? It's right on schedule. So what do I do? Well, ask someone in the department to be on standby to cover your shift if you can't come in on Saturday. Well, lo and behold, what happens? She decides to get her migraine headaches on Sunday. No. So the day she worked Saturday, she had no migraine, but on Sunday she had her migraine, and she was off on Monday. So that's like almost mind over matter, you know?
Wow.
And she was fine because now she knew that her migraines would change to Sunday on the day she had to work Saturday. So it's very much interplay between the physical and the emotional, tremendously so.
Do you think can she break that cycle so she doesn't get migraines? Or
well, here's the thing. We never did break the cycle. She was just so happy that she could work Saturday. She didn't go any further than that, which is interesting because, I would have explored it more in therapy to find out why she had a migraine on the weekends in the first place.
And is that something you can do? You can kind of explore that type of, you can...
There's a lot of people... here's the thing. Medications work very well. They do. If you're depressed, an antidepressant will work. But the problem is what works the best for anything is a combination of some therapy and some medication. It really does work the best. Now, granted, medications are chemicals. And let's be honest, if you have an issue where you need more serotonin and you're not making enough, an antidepressant will provide that for you. But if what's causing the depression was some stress, you may need to talk about it a little bit too and develop some coping skills. And the medication isn't enough to make it stay away. It may be enough. The medication may get you better, but it may not keep you better because you never change anything and you're going to fall in the same cycle over again. So that's the problem. And that could be a real issue with people that have repetitive patterns while they get depressed over and over again because, the medicine gets you out of the problem, but it's like anything else. If you're in a building that's on fire, well, I could spray a hose on you so you don't get burned, but unless you leave the building, eventually you're going to wind up getting burned. That's what a lot of people don't realize. So sometimes the therapy is critically important to changing your patterns of behavior and your defenses so that you're not at risk for the depression having to come back again when it's over.
So I guess it would be kind of bad practice to just send someone off with some pills and say, have a nice life.
Well, that's the problem. Years ago, that was always an issue because most of the medications that psychiatrists prescribe, people don't realize were prescribed by family doctors. 70% of the psychotropic medications are prescribed by family physicians. And traditionally, when you wanted to commit suicide, you told your family doctor you were depressed. They put you on medications, gave you a prescription, and you overdosed on it. That was the pattern. So you had to be really careful. And medications for depression take a while to kick in. They're not medications that kick in rapidly. So there's no such thing as an emergency antidepressant that works instantly. It takes time. It takes a week or 2 weeks to get some positive response. So you need to be really careful that the people you're giving these antidepressants to aren't at risk for suicide or they're losing their hope. Their, hopelessness, helplessness, suicidal thoughts are, precursors to, suicide attempts, and you have to be really careful about that. So yes, I think some therapy initially with some of the medications is a really good idea. So just giving somebody some pills and saying, hey, you're going to be great next weekend isn't really good advice.
Right. And do you find a lot of it, is the majority of, the things that you've seen anyway, would you say it would be a long-term medication, or is most antidepressant, anti-anxiety type medications, are those short-term, or does it really just depend on the person? And what's the majority in the people that you've seen?
It does depend on people, essentially, what your lifestyle is. If you came to see me when you're 40 with a depression, I may think that depression may have a genetic component. Because at 40, you're not supposed to have a depression. You should have a depression when you're in your late teenage years because there's a peak of depression. And again, when you're in your 60s, 70s, and 80s. But if you show up and say, I'm depressed and I'm 40, I'm going to look for situational causes, but there may be a genetic component. If there's a genetic component to your depression, you may need to take medications long term. But think about it. You're skiing down a mountain, you hit a tree, you get injured. Well, the injuries heal. You don't have to wear a cast forever. You don't have to wear bandages forever. And that's the thing. There was a time in the 80s when the pharmaceuticals said, well, if you have a depression in 1980 and you had a depression again in 1990, we should have treated you from 1980 to 1990 for the depression, which is silly. It's like saying, look, you have a strep throat. I'm going to put you on penicillin for the rest of your life to protect you from a strep throat. You wouldn't do that. So, yes, there are some patients, some people, that if they're depressed, it may unlock some genetic issues that may make them more prone to chronic or recurrent depressions. But a lot of times the depression is situational. And once the situational stressor resolves, they get to cope. The medication should go away, and you shouldn't take them forever. When they did studies of antidepressants in the 80s, we had the older-fashioned antidepressant medications, and there was a little difference in ethics in what they were allowed to do back then. So people would get better from their medicine, with the medicine, and they would stop the antidepressant. And they found out that after 2 months, the risk of recurrent depression was almost minimal. It really went down remarkably. But it didn't recover to normal until a year later. So you really wanted to prescribe the medications for at least 2 months after a full recovery from the depression. Otherwise, the symptoms were likely to come back. Well, we really don't do that anymore. We can't just treat you for depression and say, oh, you're better, we're going to stop the medications and watch you deteriorate. So we can't repeat the studies with newer antidepressants, but as a rule, you keep the medications on board conservatively, 4 to 6 months minimally, maybe a year, and it depends on what the symptoms were. If you came to me because, well, you lost your interest in your favorite TV show, you weren't really emotionally accessible to your partner, you just lost your joie de vivre. Well, okay, I'm going to keep you on the medications for maybe 4 to 6 months. And I'm going to watch what time of the year it is. Winters have a high incidence of depression. So I'm not likely going to stop your antidepressant in January or February. I'm going to try to get you into the May, June, and then taper it off. Because more than likely it was situational and you'll be better.
And taper, you said.
And taper. I would just slow it down.
Not just
cold turkey. And wait for nicer weather. Now, here's the thing. If your depression brought about suicidal thoughts, and you may have had a suicide attempt, now that's a more serious depression, and I can't risk that. So I'm going to be more conservative with my treatment, and I may treat you a whole year with the medications, because that I can't deal with. Because if you have a rebound depression when all you did was just lose your interest in your favorite TV show, well, that's not much risk. But if you were suicidal, I'm concerned. And now I'm going to be much more conservative with my treatment and monitor you more closely. And as we taper the medications, we're going to monitor you to see if the depression comes back. So that's the thing. Now, if you came to see me and you're like in your 70s and 80s and you had a depression, I'm likely going to keep you on a low dose of the antidepressant for a long time, because at that stage, it may be that your depression isn't situational. It may be biologic because you're getting older, and that's what happens when you get older. The prevalence of depression goes up. So late 60s, 70s, 80s, 90s, you have a higher prevalence of depression, and that may just be biological. I've seen a lot of people in their 70s and 80s who were financially successful. Their families did well. Everything was fine. There were no stressors in their life, but they started to develop depression. So that was kind of a biological depression, where your antidepressant center was just simply not working very well because you were older. And the medications need to be kind of forever, to keep the depression from, hurting you.
Is that due to just, you said getting older, so it would be, your brain or your
whatever system you had that helps you, because we have two neurotransmitters for depression.
Right. Okay.
Epinephrine and serotonin. So it's possible that as you get older and you hit certain ages, like late 70s, 80s, 90s, that system isn't functioning as well. As a matter of fact, we know it's not functioning as well, because if I were to treat you for depression, in your 30s and 40s, I would wait 2 weeks. If I saw no response, I'd either bump the medicine dose up or get rid of it. But if you're in your 70s or 80s, I'd take my time, because you're older, your biology works slower. So it may take longer for an antidepressant to kick in. So I'm going to give it more time. I'm going to give it the benefit of a doubt.
Right. Your whole metabolic system just slows down. So
it does. So you may take a lot longer to respond to an antidepressant.
I see. I was also thinking, as you get older, also, the impending end of life kind of sits with you longer. It is possible that could be a factor, because a lot of people do fear what happens when they're gone. And a lot of people, well, actually, it's funny, because most people that have the midlife crisis, it's much earlier than the 70s, 80s, 90s, because a lot of people in their 30s and 40s are saying, I'm not where I should be in my stage in life, and they get very depressed.
Now, a lot of people in their 70s, 80s, and 90s, well, they don't seem to do that as much, to be honest with you.
Wow.
A lot of patients are very comfortable with their age. It depends on your circumstance to a certain degree. If you're doing well, you have a good family, good support system, life's good. But I've seen patients that have had that and still got depressed enough to try suicide because they felt, well, I'm doing well, life's good, but what if I'm a burden on my family? And that just,
Wow.
took their, that was their focus.
Yeah.
Even though everything was fine, that what if, and that what if was enough to tip them over into depression.
Actually, I can relate. And you also brought up a good point of being in your maybe 30s and 40s-ish. It starts to, start to feel it at 30. I mean, I started to feel it at 25, and, I'm doing stunts. So I'm actually noting my recovery times from when I was 25 to when I was 35 to, and I'll stop there so no one can actually know my real age, my actual age. But, as you get older, I want to be where I was. And the more you want to be where you were, I'm just not 20 years old anymore, and I can't go back there. So I could imagine that would be a source of, like you said, depression.
It can be, definitely. There's no question. As you're going from one stage of life to the next, those milestones can really affect you. They really can.
Yeah, you're finally realizing, oh, wait, nope, can't do that anymore. Can't do that anymore. But that's okay. Can do other things. So this came up a lot. And it's something that I kind of asked you in passing as well. And I briefly mentioned I was diagnosed with ADHD as an adult. I was in therapy with my wonderful therapist. And for over a year, she was suggesting that I just take the test. She had like a clinic that I could go to. And she's like, even if you don't get medication, it'll give us both a little insight. And I eventually did and did the testing. And I actually was doing pretty well at some of the little tasks and things. And I was like, does that mean I'm good? And they're like, oh, on a scale of 1 to 10, you're an 11. So I was quite shocked. I didn't think that would be the case. But knowing that I did suffer from dyslexia when I was a kid as well.
Well, with dyslexia, you have some issues with reading and written words. And that could really affect people. And it could be mistaken for ADHD. There's no question about it because, it's hard to be not distracted when you're trying to read something and it's just not working really well. So it does make for a bit of difference. As far as, treatments and differences, way different, but the dyslexia is a problem, and there are no medications for it.
Right.
And it is an issue for a lot of people because it is really a handicap for a lot of people. It does compromise their ability to function, and reading is the best thing. A lot of people would get tutoring because you had to get all your education verbally. You couldn't get it from reading because you couldn't trust what you were reading. You couldn't see it really well because of the differences with dyslexia.
I just, again, I'm going back to myself because these are questions that I had, and I know there has to be somebody else out there that has also been told they were dumb, and they're, slow in reading or they're, not capable.
Yeah, exactly. And that's one of the misconceptions. Well, you can't read. You can't do it with a good flow. Well, you must be stupid, and that's not really the case at all.
Or not trying.
Or not trying. That's right. There's no effort. You're not making the appropriate effort, which is another issue too.
Or another thing was, you're just a bad kid and not paying attention. I'd imagine I had some sort of attention deficit as a child, just looking back. I was a toe tapper. I was a, daydreamer. All those cute terms they give to kids who just could not give a flying rat's butt about what's going on in that classroom because they're just over it, or they're just focusing on different things. And again, you're made to feel stupid or dumb or bad, a bad kid, just not paying attention and stuff like that. So, I just learned to be quiet. When I was younger, I barely went to school in high school. I think I made it to half the days of school in high school, yet somehow made it through with straight A's because turns out I wasn't dumb. I just had trouble reading and paying attention. You've seen people and patients with ADHD, and we were talking about that.
Yes.
And do you diagnose can you, like, without going through some sort of like a test or something? I mean, you're...
Well, you can see some symptoms of it,
Right.
but do remember, one of the things I do is I see a lot of patients with anxiety, depression, substance abuse issues, and that can mask the diagnosis of ADHD. So you don't know. Sometimes you don't know. But sometimes you see a patient who has no substance abuse issues. They're depressed, they may be anxious, and you do testing. We do testing all the time to screen for it. The problem sometimes is their level of anxiety, their level of depression is so high that even though they see issues with attention deficit, they don't know what the etiology is. Is it primary ADHD? Is it secondary to a depression or anxiety? And that's one of the downsides. Here's the problem, too. People with ADHD, because of the ADHD, can be more susceptible to depression and anxiety and substance abuse. So it's a catch-22. It's like, well, okay, you're masking the symptoms because of the comorbidity, but at the same time, well, which came first? We don't know sometimes.
Is that where therapy would come into play?
Well, here's the thing. Medications and therapy are the hallmark treatments. There are some cognitive behavioral therapies for ADHD to help you cope with the symptoms. And there are medications. The problem is the pendulum in pharmacology right now is such that, if you're taking an amphetamine or a narcotic or a benzodiazepine, they're highly addictive medications. There's a big issue. So getting physicians to prescribe some of these medications, the stimulants especially, is very hard to do. I had a patient who was doing beautifully on her stimulants, was referred to, she had to see somebody else for treatment, and they refused to give them to her. So she deteriorated completely, which is sad because she did beautifully on the stimulants, but because she was an adult with ADHD, well, there was the question of, is there a potential for abuse? Is there potential for diversion of the medications? So they decided they weren't comfortable with it. And I have to be honest with you, sometimes the stimulants work the best for ADHD, and you have to monitor their use so that there is no diversion or substance abuse, but they work. They work very effectively. There are other medications you can use besides stimulants for ADHD, but I have to be honest with you, the stimulants are the hallmark treatment that work the best, and they really do. And the problem is you have to sort things out. Is the patient going to be compliant? Are they going to do what they're supposed to do? And then you have to do a trial to see if they actually have a response to them. Critically, you have to do the testing, because if you want anyone to give any credibility to the patient who's taking a stimulant, if you don't have some testing that backs up that there's some ADHD, you're not going to get them willing to participate in treatment. Right. And the worst, we have a lot of patients who've had a history of substance abuse, and it's been horrible. Cocaine, methamphetamine, they smoke marijuana, they do all kinds of things, and now marijuana is on the cusp of being legal. So most people are just omitting that from an issue. But the methamphetamine is very popular these days, so is cocaine. And the problem is if you have a substance abuse issue, now you have some legitimate ADHD symptoms, no one in their right mind is going to give you prescriptions for an amphetamine. And that's the problem. It's like, I'm sorry, you kind of, with your behavior, have put yourself in a position where that's just not going to happen because of the concern that it's going to be abused. And the weird thing is, if you look at statistics, I think Harvard did a study, I think in 2017, and they felt from their study that childhood ADHD, if you had it when you were a child, that there was an 85% likelihood you had it when you were an adult. You have some form, some residual symptoms of the ADHD. And I got to be honest with you, those are patients that are not in treatment for it. And a lot of times you don't spot anybody. People in grade school can have ADHD. People in high school can have ADHD. I used to work at one of the local colleges seeing patients, actually two of the local colleges. We saw a lot of patients with symptoms of ADHD, and we put them on stimulants, and they became wonderful students. But they never were diagnosed before. And the reason they weren't diagnosed before is college is very laissez-faire. Here's your book, here's your chapters, we have a test in 2 months, and here, learn it. High school is very regimented and very, here's your homework, you do it, we'll check it tomorrow. Well, there's a lot of structure to high school. There's a lot of structure to middle school, a lot of structure to grade school. A lot of patients get away, a lot of people get away with it because the structure keeps them doing okay. But now you're in a situation in college where it's like, you need to learn it, and we're not going to supervise that much. Now they're having a problem.
Wow. And
they'll tell you it takes them 3, 4, 5 hours of studying to actually record an hour of information.
Yeah.
And then when you put them on some medications for it, it's a marked improvement. I had a girl that we thought was bipolar. because she had mood swings. She kept quitting jobs. She just lost interest. Tried everything, mood stabilizers, antidepressants, anti-anxiety medications. Nothing worked. Decided, well, wait a minute. You said your focus seems to go away. Tried her on an anti-ADHD medication, and it worked beautifully. She not only liked her job, she kept it, got a promotion, and decided to go back to school because it made that much of a difference in her ability to attend to tasks, which she had lacked before. So the combination of some medications with some therapy is the best combination for ADHD. And to be honest with you, like 4 or 5% of people in their 20s and 30s have ADHD. And if you had it as a child, there's a high likelihood you have some of the residual symptoms as an adult.
Now, what's the H is hyperactive?
Well, it used to be ADD and ADHD. ADD was attention deficit disorder. ADHD was attention deficit hyperactivity disorder. We use the DSM-5, which is a new compendium of how we diagnose.
Okay.
ADHD is all that exists now. ADD went away. But ADHD exists in 3 forms. It means the hyperactive form, the inattentive form, and the combined form. Some people aren't hyperactive with their ADHD. They're just simply inattentive. They have the attention span of a fruit fly, essentially, and they can't focus. But they're not hyperactive at all. Some people have a little bit of both. They're hyperactive and they have issues with inattentiveness, and some people are just hyperactive.
Now, is the hyperactive someone that would have the hyperactivity? Would that be a constant, or is that kind of
to be honest with you, in my experience, and again, I can't say this, clinically, this is the way it works, but most of the times, the hyperactivity seems to focus mostly on children. If you see teenagers, adolescents, children, they seem to be the hyperactive variety. When people get older, the hyperactivity seems to go away, and it's just replaced by a lot of inattentiveness, just the inability to focus or to focus on task.
Wow.
And I've seen this in college students where they can't keep a part-time job because they can't quite focus. So they kind of leave things go, or they'll start something and not finish it. And they got to let go. And you put them on medications, all of a sudden they can focus. They can attend to tasks. They get promotions. They get raises. They get positive job things. I had a girl who was funny. She was diagnosed with ADHD, and she was taking medications for it, but a lot of people take a holiday on the weekends because they're not doing anything structured. Well, their parents liked to go into New York City, and they enjoyed the trip into the city, and she dreaded it because she had a horrible time. She just really hated it, and she loved her family, but she just hated the trips to New York. So I suggested to her, why don't you take your medicine when you go into New York? Just see what happens. She took it. She couldn't believe the difference. She didn't realize it, but the trip into New York with her family was far more structured and far more regimented than class was. So her ADHD medications made her tolerate it incredibly well, and she had a really good time. So whenever she was going to go into New York with her family, she took her medications because it was like a school day, because that's the way her family worked. That's what worked for her.
And I have one more kind of point on this, and then I have a really good question. Do you find that it becomes, and you said she takes a holiday, like she doesn't take
a lot of people
weekend.
take what's called a drug holiday, because if you're going to school during the week and Saturdays come, suppose you're a university student, you're going to a party Friday night, you're not getting up early on Saturday. You're taking a long-acting form of an anti-ADHD medication. So you take it in the morning and it lasts to, say, 4 o'clock in the afternoon. But this particular Saturday, you're going to sleep enough your party from the night before. You have no activities. So why would you take your medication? You don't need it. So a lot of people don't do that. They take a holiday when they're not doing anything structured. And it seems to help the medications work better, because sometimes with the amphetamines that you use, they can downregulate receptors and maybe reduce their potency over time. So a drug holiday is not a bad idea. A lot of students, a lot of kids, when they're on summer break, will stop their medications for ADHD over the summer and then go back on them in the school year.
So these are very different from, just to be clear, if I were listening to this, to a very different type of medication than something like an antidepressant or anti-anxiety medication, because it doesn't.
Well, there are non-amphetamine or amphetamine derivative or non-stimulant treatments for ADHD, but by and large, they're not as effective as the stimulants are. Let's be honest. I mean, in my experience, I use Strattera. Strattera is a medication you can use for ADHD, which works like a stimulant, but it's not quite one. But it does work for some people. It's very effective for some people, but not for others. Then there are other medications we use too that seem to help with attention deficit. But again, they're not as good as the stimulants are in helping with those symptoms.
So doing something like taking off a few days, which is actually what I do personally, because I found that they do become tolerable, and you need to increase you get used to it almost.
Yeah, you can. You can say, look, it's not as effective.
Right,
as
not
it
as
had
effective.
been.
Yeah, I think that's something to keep in mind. You said there are a lot of medications. Well, there's more than just depression, anxiety, and I know I recently had a friend diagnosed with schizophrenia that was in her family, she's a fully functioning individual, and I think a lot of people have this misnomer, this misconception of what schizophrenia is, and they think of, a lady in the park, talking to the birds or talking to people out loud, and they think they're dangerous, and can you give us just like a quick definition so I'm not...
Well, schizophrenia is a disorder of thought. It's a thought disturbance. You have hallucinations, delusions, you can have agitation. That's the positive symptoms of schizophrenia. So those are the ones people know, they hear about.
Okay.
People are hallucinating and they're delusional. But there's also negative symptoms. It's a paucity of thought where they're kind of flat. They're kind of asocial, and they kind of stay on the fringe of society. So these are people that don't marry, they don't interact. Now, there are exceptions. I've had a lot of schizophrenics who were married with children, but the reason for that was they got married before they had their psychotic break and before they were diagnosed with schizophrenia. I actually treated a physician who had a psychotic break in the beginning of his schizophrenia when he was a resident, when he was an intern. And he managed to get married to the nurse that he was engaged to, managed to have 2 children, and managed to survive doing medicine and still function. But he was on medications for schizophrenia, and he retired, and he went off to live near his children who had moved to the Virginia area. And he had a successful outcome in his life. But the sad thing was he had some of the symptoms. He was flat. He had a flat affect. And that was from the medications, though, largely. Sadly, he was from a generation that didn't benefit from the newer generation of the medications we use for psychosis, which actually give you a better outcome. The older medications could get rid of the psychosis, but they'd make you flatter, and they'd make you more withdrawn. The newer medications give you a little bit of spark. They help you with your depression, and you function better.
So it is definitely a livable, diagnosis. Like it's not a death sentence, or
it's not a death sentence, but it's a serious condition, and it's not very prevalent in society. It's very rare.
Wow.
It's less than 0.1% of the population, so you don't see very much of it. But it is a pretty serious illness. But you can, with medications, you can do a really wonderful job of making the symptoms in remission, and people can function normally.
I totally got off track, but my dad was telling me about a woman who was, diagnosed and just didn't understand it, and went and learned about it, and then became either a doctor or she got her master's, but then now she speaks about it and she has her symptoms under control. I'm guessing.
Yeah, there's one woman, I can't think of her name. I can't remember her name. She founded the whole concept of personal medicine. And she said that she was diagnosed with schizophrenia, beat it, wound up getting medicated and treated for it. And she now has an entire paradigm on how to deal with people that have mental illness issues. We were using the personal medicine fund for a long time, and that's a very big thing. So she started a whole movement, and she is apparently a schizophrenic in remission.
Do you know her name offhand? Because
I can't remember her name.
I can put it in the notes because I think that's noteworthy.
She's very famous. She's at least currently. I can't think of her name, but that was a big movement, a big changeover about 5-6 years ago in the field of psychiatry, with this whole concept of personal medicine, and that was because of her contribution to it.
That's pretty amazing to have a personal, experience with it and want to change it and make the world better for it, and have people not maybe have to go through what she went through, or like you said in the past, I know they would just throw people in my dad would say the padded room, or
pretty much
that imagery we get of the of people, in a psychiatric hospital that are in straitjackets and in padded rooms. And now it's kind of like you strip away the layers of, why that's happening and what got to that point, and the treatments, like you said, can really...
They're life-altering. They really are. If you
bring life
get
back
a patient with a good support system and you get them on the medications, they do very well. They really do.
That's just like mind-blowing to me to see, like, what they used to do to people, and like lobotomies, just because they needed to just, they thought people were crazy, or crazy and insane and all this. And I mean, we can go down a whole path on like
the whole rabbit hole.
Yeah. Sociopathic. Whatever.
Hey, sorry to interrupt, but I could not wait another second before telling you about Pittston ketchup. It's grilling season, so you're probably going to want to stock up on my favorite condiment of all time for anything you might be grilling. Meat, veggies, beyond impossible meat, garden, burger, dogs, or whatever. Anyway, it's delicious, simple, easy to pronounce and digest ingredients make this amazing ketchup the perfect addition to any meal. You can get a discount if you go to www.pittstonketchup.com. That's PITTSTONKETCHUP, the way you spell ketchup.com, and use code HungryStuntGirl at checkout. Okay, back to the show.
The last thing psychiatry related I wanted to kind of touch on was the accessibility of therapies. And I know that it's such a privilege for a lot of people to be able to get the help that they may very well need, and to survive or to get through crisis. And I know you see patients that get to that crisis situation where they're in the hospital. They may not have the money, and they end up, really damaging themselves, or, attempting suicide. But is there, I know there's an app called BetterHelp, for instance, and I'm thinking there are getting to be better ways of getting help, but then there's still that stigma attached to it, so people don't want to seek people out through their physicians because they're afraid that that's going to negatively affect like a decision, or buying a gun, or something. That's just a
well, there are some
example,
concerns about that, but the stigma largely is getting better, because 1 out of 4 Americans at one time in their life are going to seek some kind of mental health treatment. So it's pretty prevalent. 25% of America is going to be in treatment at some point in their time. Now, will they see a psychiatrist formally? More than likely not. Most of the times, the antidepressants are prescribed, treatments are prescribed by their family doctor. And if they need some therapy in addition to the medication, they get referred to a therapist. And there are a lot of people doing therapy. The big thing, though, is if you don't have money, if you don't have insurance, if you don't have any resources, your county will. So if you live in, say, Luzerne County, like in Pennsylvania, where we're at, there is a counseling center that'll see whether you have income or not, whether you have insurance or not. It's free. The service is available. Also, there are support systems. There's a hotline if you have suicidal thoughts.
Right.
There's a warm line if you don't, if you just want to talk to somebody. There's actually a warm line where you could talk to somebody and just, spitball about what problems you're going through, and they may help you. And there's even programs that are respite centers, like we have in Wilkes-Barre. We have the CRRC. It's called the Crisis Recovery Center. You can go in there for a respite. If you're not suicidal, but you're distressed, they can actually take you in and house you for a couple of days to give you a safe place to go, like a respite center, just for a couple of days, or a sanctuary for a little while. So there are a lot of resources. The sad part is most people don't realize what resources are available.
Right.
And as such, a lot of them just go, people just don't avail themselves of them. Even for the geriatric population over 65, there are lots of resources out for elderly people that most people are unaware of. And as a result, they just go not used at all, which is so sad.
So I'm going to put a link in the show notes just for people to just get an idea, or where they maybe can search depending on the state that you live in.
Right, state and the county. Usually everything comes from each individual county, and the county will have a mental health office, and they'll offer certain amount of services, and a lot of the services will include a warm line and a hotline and a crisis center that you can call. In Luzerne County, they even have a mobile therapy program where they'll come to you and they'll see you with the mobile therapy team to see if they can help you, assist you with any emotional issues you have.
And it doesn't necessarily need to get to the point where you're contemplating your life.
No, absolutely not. If you have some issues and you're not feeling well and you're seeing some drop in your ability to function, that's the time to call somebody, not to wait until it gets even, too late, which is what a lot of people, unfortunately, they're not sure what to do. So it gets so bad that they wind up suicidal, when you could call somebody when you have the least little bit of problem and just start to get some therapy or some treatment for it, to talk about it at least.
That's great. That's great advice. And it feels like it could nip it in the bud, before it does get to that point
It would
where
help.
you're
It would
in the
help
crisis
a great
center.
deal. Absolutely.
Yeah. Wow. Well, and that's a big one. So I'm definitely going to put that in the show notes. Maybe put some links. I see people kind of posting on Facebook here and there, like, do you have how do I get therapy? I can't afford this. I can't do that. Or perhaps they make enough money where they can't necessarily get what they can afford.
Well, some people actually sadly have insurance, and the insurance requires a copay,
Right.
and they can't afford the copay. So you can see the doctor, but $25 here, $15 here, they can't afford it, and as a result, even though they have good coverage, the coverage does require some pay out of pocket, and if you have kids and you have other issues, it may just be not affordable.
Yeah, I know.
So that's
there's
another issue.
Complications with insurance, just
Oh,
left and right.
absolutely.
You've been going through your
And you only have so many visits a year with some insurance providers, so you have to be really careful how you use them.
Yeah, that becomes
Yeah,
very
becomes
confusing.
problematic.
Back to food, because it's all tied. Because your mental health is also not only by the physical, but by your nutrition. You had a pretty bad health scare, and then you kind of changed your
did.
diet up, and
Yes, I did.
so you firsthand know how diet and nutrition can just change your body, and therefore your mental health and all that. But what did you? Can you talk about?
Well, I like intermittent fasting. That's my favorite.
Got it.
I like intermittent fasting, and I'm not really into keto, but I do that a little bit.
Yeah, so less of the
So
carbs.
if I have a breakfast, it'll be a keto breakfast, and I try to keep keto. But I feel you shouldn't say no to anything in particular. So I'll
Right.
give myself permission to eat whatever food group I want. But I try hard to stay focused on healthy stuff. Yeah.
And when you, I have two questions that I ask people, and I talked so much and asked so many questions about other things, so we didn't get to talk as much about food as I normally would. But I think we got a lot of people actually wrote in and asked a couple of the questions that I was asking, so we got some of that out of the way. But if someone gave you whatever ingredients you needed to make something, and I know you can cook, so I know that you could do this. If someone gave you all the ingredients to make one thing, and you had a recipe or maybe people to help you, and you could make it at home and eat it, what would that be? What would that meal be?
Meal would be poached lobster tail and fettuccine Alfredo with crab sauce. With
Oh,
crab.
that was easy.
Yeah.
Wow.
Not a problem.
You're like, I got
It's my
it.
favorite meal. Fettuccine Alfredo with a crab on it, and then just a nice lobster tail with drawn butter. I love it.
What now? Okay, so what kind of crab?
Lump crab, the really
Got
good
it.
stuff, the lump crab, so that it's nice and poofy. It's
Yeah,
not
not
this
like
shredded stuff.
shredded,
It's and you just lay it on top of the fettuccine Alfredo, and it just
And
goes
how do
so
you
well
poach?
with.
How do you poach your lobster?
Well,
Butter?
we used to boil them, and then everybody's telling me to steam them. But we decided a couple of years ago, my brother and I, who's also an amateur chef, we started
Nice.
poaching them in butter, and it came out so well. That's what we do now. I poach everything in butter.
Okay, now I need to learn how to do that.
It's
Hey,
great.
That's cute. Well, maybe not the fettuccine.
Just have to
but,
control the temperature and put a little bit of water in the butter so it doesn't break.
Okay.
And it's just absolutely incredible.
right. Yeah, you
it
don't
just
want the butter
adds
to
a
break.
nice flavor, and it still gives you a good texture.
Salted butter?
Salted butter,
Yeah.
absolutely. There's
Okay.
no other kind.
Oh my goodness. Okay, well now this always happens. I'm super hungry. Okay, the other one is if you didn't have a lot of time, but you had to cook something for yourself, do you have like something that is just, you
A
go
go-to?
Yeah.
Rice-a-roni.
Really?
I love rice-a-roni. I just
All right.
cook a box of rice-a-roni.
It was, Blue Box mac and cheese was my buddy.
Yeah, I love
my
rice-a-roni.
friend,
Good chicken or garlic, just throw it in a pot. I
Rice-a-roni.
have it in 20 minutes. I have it ready.
Got
and
it.
I love that
Super
as a go-to.
flavorful.
Yeah.
Maybe a little processed, but hey, it's quick and it's
rice, so
tasty.
it's
rice.
supposed to be healthy. I don't know if
rice
it is or
healthy.
not.
Yeah, totally. It digests.
Just depends how much butter you put in it. That's all.
Right. Well, keto plus rice.
Yeah.
That's fine. No, rice-a-roni. And I remember actually so your kids, they're twins, and how old are they?
They're about 30.
Oh my gosh.
I know,
Okay,
isn't
I
it sad?
babysit them.
Yeah.
They're both physicians. They're
Yeah.
both medical doctors, and both wonderful human beings, just like their parents. And we used to eat these microwavable chicken Kiev frozen,
Yeah,
like breaded, butter-filled chicken tender things. That was our quick, at lunchtime. And we had our bi-weekly snail newsletter that we wrote.
Bi-weekly snail.
We
I
only
remember
made
that.
one, but It was supposed to be, but I guess it's the snail, so it was a little
Slow.
slow. Yeah, we're working on the second episode 30 years later. Any final words?
None. I can't think of any. This was very pleasant. I enjoyed it.
Yeah, this was fun. I definitely have more questions, but I'm going to...
Maybe for a future podcast.
Exactly.
Who knows?
Dr. Liskov part 2. Maybe I can get Cindy too.
There you go. She'd love to do
love that. I love. Or the kids. Oh my gosh.
There
we
you
have
go.
Like a Liskov family
that'd
podcast.
be cool.
Like the Partridge Family, only way different.
That'd be cool. That'd be very cool.
Really nice, really really smart doctors. So thank you. This was amazing.
You're welcome.
Thank you so much. And
my pleasure. It was a lot of fun.
Just another disclaimer. This is not personal medical advice. This is for entertainment purposes only. If you have any questions, please call your family physician or
call 911.
Call 911 if you have.
There you go.
If you have an emergency, and I will also include some other resources in the show notes, like I said. So yeah, thanks again.
You're welcome.
Hey, thank you so much for listening to the Hungry Stunt Girl podcast. If you have any questions or comments, feel free to contact me at heidi@thehungrystuntgirl.com, or you can check us out on Instagram or Facebook @thehungrystuntgirl, or on Twitter @hungrystuntgirl. New music has been written specifically for me by my good friend and amazing composer, Colin Bell. And hey, if you are digging this content, please like, subscribe, rate 5 stars wherever you are listening to this podcast. That is what will help keep this podcast going and growing. And as always, stay hungry.
All discussions on this podcast are for entertainment purposes only and are not meant to replace medical advice. Contrary to popular belief, Heidi is not a doctor or a nutritionist or an astronaut. Although, that would be kind of cool. Heidi, maybe you should be an astronaut.